And welcome to the EMS Underground. I am your host, Charles McFall. I'll be handling the discussions for the day. And we've got some interesting things to talk about. But of course, as I always do at the beginning of this, I'm going to hit some share buttons. I'm going to hit some like buttons. I'm going to make sure that everybody can see what's going on and talk to me. And let's be cool. No, don't do that. I made it like non-HD. Daddy likes the HD. So let me swap to myself. But today we actually have something from Jeremy Mathis. He has submitted a topic to talk about, and that is part, or at least what I'm going to do. Watch me whip. Watch me EMS nay. I don't know. I just want to get this shared out on my page. Hopefully, Facebook will make this a little easier in the future. So, of course, I am Charles McFall. I'm the media specialist here for Georgia Institute of EMS. Lots and lots of things going on that, fortunately, I am not privy to. I know I spoke a week or two ago about Newton EMS, right? Newton General is now Piedmont Hospital, and the official word was because they weren't getting the money they asked for EMS that they were going to drop EMS. That was the word that was given at the time. Unfortunately, I'm not privy to most of that because I know from what I have heard from the outside, from the fringes, from the edges, what I have heard is things are not progressing smoothly. Let's just put it that way. So that's something that I'm not going to talk about today because, fortunately, like I said, I don't know anything about it. But today, Jeremy Mathis I asked a question to all of our instructors at the school. I said, what is something that comes up often either in class or on the truck that I can address in the show? A bad habit, a wrong mindset, anything that you see. Now, part of what I want to talk about maybe is perception and how we do things. But Jeremy wrote me back and said, I've seen many, actually, you know what I'm going to do? I am going to highlight this, and I'm going to copy that, and I'm going to paste it right there. All right, now, and hit enter. There we go. Now it's in the official chat for the video. Jeremy says, I've seen many preceptors perform skills other than ways we teach for registry and tell students learn that way for class, but this is how we really do it. Now, a preceptor, if you don't know, a preceptor is who's in the field. They're the ones responsible. Usually it's a paramedic. It can be a higher level, like a paramedic captain. It can, I guess it could be an EMT for EMT students. It could be an EMT thing. I'm not sure. Did I not share that? I thought I was sharing this. Share. Nope. I put the wrong thing. Let me write this again. That's me. All right. There we go. That's what I was trying to do. All right. That was stupid, but it doesn't matter. So preceptor is the one who's responsible for making sure in the field the students are doing the right thing. The proper procedures, being safe, those kind of things. So that's what a preceptor does. All the students ride with preceptors on third rides. And hopefully, actually, when you start a new job, you actually have a preceptor there for a few rides just to make sure that you're ready to go and can get on a truck by yourself, whatever. And I took that, even being a medic for 10 years and having been a captain in two different places for multiple years, I absolutely, when I got my last new EMS job, I was like, nope, I will ride the 3 8-hour shifts before I can get let loose on truck. That's fine. I do want that ability, that time, that opportunity to learn how you do it here in this service versus somewhere else. I like the opportunity to learn how the politics kind of work. I just want to fill everything out. So absolutely, preceptors are good, except when you tell somebody learn that way for class or for the test, but this is how we really do it, that can mess things up for people. That can teach bad habits. I would like to know, there's a few people watching, and I know this is live. Most people get this after the fact, and that's fine. But I would like to know, if you can mention it live, if you've ever said this and the reasonings behind it, why you might have said it. I'm trying to think in my career if I ever did something like that. If I did, let me put it this way: if I said something like that, I have no recollection to the court. I have no recollection of saying that, Your Honor. So I'm not. I really don't, because I do remember thinking, watching people. Oh, I can't get a vein, and pulling the tip off their glove. That's weak sauce to me. I've seen people. I just can't find. I can't stick a needle with a glove on. That's honestly. I have no concept of why you do that, because I've never had any problems, gloved or otherwise. I mean, if this is a difficult stick, it's a difficult stick. Your glove doesn't really change that. And mentally, we go, but it's this latex, it's this rubber, it's this what. Either the vein is there or it's not. Now, I've done a number of blind sticks where anatomically, okay, it should be here. It should be roughly right here. Let me see, but I can't see it. I can't feel it. Let me stick. And every once in a while, that worked. It worked. I got a good stick. But Jeremy's saying that the proctors, the people teaching, the people who are supposed to be responsible for your education in the field are saying learn that way for class, but this is how we really do it. Here's why I do EMS Underground. I want to discuss the things that aren't taught in class, right? I discuss how to keep your sanity, how to keep your health, how to have healthy relationships, how to survive the critical incidents that aren't critical incidents. So a critical incident is mass casualty, right? It's anything that overwhelms the system. But for some of us, I talked about this last week, a critical incident could be, the kid in the car, that one triggers us, whatever. Those are the things I talk about. So this is something I want to talk about. Old school versus the correct way to do it, I guess is the best way. Good old boy system. I'm an expert versus that's how the book teaches. And I do need somebody. It would help if somebody could say, well, this is how the book teaches it, but this is how I do it. So it'd be a good discussion. And I understand that there's only 3 of you watching, and we might not have that discussion. And Nicole, I know you volunteer. I know you're a firefighter. I know you're around all this stuff. If you've heard somebody say this, I'll take it secondhand. It's not about hating on somebody or bashing on somebody. It's about having that discussions. So, he says also, he goes on to say, not wear proper PPE. It depends on your definition of proper, but that does bug me. Technically, proper PPE for sticking an IV or doing an intubation is goggles, sometimes a mask. I cover my whole mouth as I'm trying to speak on the show. Sometimes a mask, definitely gloves. Gown can even be part of it, depending on the situation. Terry Dearman, thank you. The problem I see is some proctors either don't care anymore or the book says it this way. Yeah, I agree, Terry. And that's exactly where I'm going into. But I can't remember which service is that. There was a service that basically in their protocols, it was pulled directly out of a very stiff textbook that said PPE for an IV stick is goggles, a mask, possibly a gown. I can't remember if the gown was included, and definitely gloves. What do we always do, though? Gloves. Well, okay, always is a very, very bad word to use here. What are we always supposed to do minimum is gloves. I remember being a brand new EMT. I was third riding. Actually, technically, I wasn't even a brand new EMT. I was an EMT student. And I was third riding in Athens. And I cannot remember the names of the medics I was with. They were good guys. Actually, it might have been a female and a male. I don't remember. But they were very much in that vein of educating me, helping me out. They're excited about their profession. Absolutely. What can we do to teach you, tell you our stories, help out? And we went on a call. Of course, it's forever ago, so I don't remember. 1996. 1996 is when I started EMT school, if that dates you at all, dates me at all. Some of you possibly watching were not maybe even born when I went to EMT school, and that's an interesting concept in my brain. Because I feel young. I mean, I feel good, and I'm be 40 this year, and that's still not even. And if you listen to any of my other shows, I think about things that are different than other people, but even in normal society standards, that's still young. And so I don't think about, wow, EMT students today, it's possible you weren't born, or when I went, no, yeah, 95. 05, 50. Yeah, it's possible you weren't born when I went to EMT school. So they were sticking an IV. So it was, and you're gonna kind of see it back. So it was medic, and you on the camera is me, and the patient. My face is the patient, right? That's the view I had. So you're medic, me's the patient, you're me. And I'm watching him do a live stick, and man, I'm the epitome of a good student. I just eat up information, and I'm just there, and I'm staying out of the way, but I'm watching him get the stick, and he gets a good stick, and there's blood comes in the cap, all right, and he holds it like he's supposed. PPE, everything, he holds it like he's supposed to, pulls the needle out, and shot of blood like the Matrix, man. I like kind of ducked and moved and saw the blood go shooting past me because he had hit an artery. He accidentally hit the artery. And, of course, they dealt with that, and they laughed about it later in the truck and told me about it. They used it as a learning opportunity, teaching opportunity, instead of being like, don't ever tell anybody. No, they said, no, we messed up. Sometimes it happens, and we hit an artery. Either that. It is possible, actually, because it's so long ago, it's possible now with what I know that this guy, the patient, had super high blood pressure. That's a possibility, because I think with him holding the catheter, but obviously the catheter wasn't fully closed, right? But holding it down, holding pressure, it possibly turned it into like a water hose, when you hold down. And if there's enough back pressure, like high blood pressure, and I could be wrong. These are just me kind of putting pieces together from my memory. It could have been still a vein and just had a ton of pressure on it. Again, I don't remember what they're for, but that's what I remember. And they use it as a teaching example. Okay, here's what you do. You don't act unprofessional. You don't, go crazy about it. They just held pressure. They didn't try to push fluids anyway. And I cannot remember the color of the blood, because I know now, my memory is hazy, but then I was just all in the moment. But I know bright red blood versus dark brown blood. So they were professional about it. So, okay, what we're going to do is we're just going to hold pressure, make sure it doesn't do anything, and do a line on the other arm. So it was a great learning experience. They were great proctors. I've had proctors tell me, sit down, shut up, and sit in that seat. And whenever we went out for a call or something, of course, I'm in the back. I had a guy pull up to a nursing home, and it was too low for the ambulance, and they all knew that. But he tried to pull as close as he could, and he hit the overhang with the ambulance, which hit my head on the wall because I'm sitting in the captain's seat in the ambulance, It was, there's some good proctors, some bad proctors. But Terry says part of PPE when starting IV is using sharps container. Yes, Terry, using the sharps container and not stabbing the bench, because that's, and hey, Johnny, glad to see you, man. That's super important to mention, Terry, is that here's a bad habit I did. I will go ahead and tell you, this is textbook bad. This is wrong, but I did it a lot. You have the caps. You get the needle off the shelf. And obviously I don't have any good stuff. You get the needle off the shelf, and it has the cap on it, protecting the needle right before you stick somebody. I did that a lot. Bite the cap, pull it out, stick the... Never recapped it. Even with this quote-unquote safe method where the cap is sitting there and you just kind of scoop it. No, man. Sharps container. Where I'm sitting on this jump bench, my sharps container was always right here. If I'm sitting in the captain's seat, it's right on by the cardiac monitor. If I'm sitting in the jump seat, it's still right there by the cardiac monitor. There are sharps containers everywhere on every truck I was in, man. And in the house, we had portable sharps containers. God, stabbing that bench seat. I talked about that a week or so ago, so I won't go off totally on it. But that was damn crazy. So yeah, we're talking about people. Put your gloves on. I don't care how long 20 years in the field does not defeat disease. 20 years in the field does not defeat contamination, cross-contamination, viruses, what you bring into the house. Oh, gloves are not going to protect you from a stick. No. Well, theoretically, it could. Theoretically. If you got stabbed with a needle, quite possibly the rubber could help protect you some of that, because it'll get whatever. But no. I got to sneeze. I hate when I have to sneeze, especially when I'm doing a show and it's not coming. Here we go. There you go. There's your proctorship right there. That's how you sneeze in the back of a truck. Just make sure you get it everywhere, all over the patient, all over the truck. Yeah, working a code, it's very easy to make a mess, but you always have to know where your sharps were. And I love the retractable needles. I'm using this pen as like my play needle, I guess, today. But I do love I think there's dust on my freaking microphone. I was nice and clear all day long until I sit down and get my face right in this thing. So it's quite possible. It's quite possible I've got disease on my microphone cover because I cannot tell you the last time I washed this thing. That's not what you wanted to know. But I do love the retractable needles. Those are nice and safe. So technically, even though it's stupid and bad to just put it behind the bench, technically it's safe. Terry, you're on point with that. The sharps container is absolutely personal protective equipment, and so many old timers don't do that. It goes right into the bench, or worse, is sitting on the ground just open. That will get you verbally assaulted in front of a patient if you do that with me. I never stood for it when I was on the truck, and I sure wouldn't stand for it now. If I was the patient and you did it wrong, I would yell at you. You know, that's not right. The poor attitudes. Well, okay, poor attitudes. Here's the thing about proctorship. I am going to play the defense on this poor attitude topic. Because I have talked about burnout. I've talked about you don't know the day somebody's had, the divorce they might be going through at home, the financial stress. I mean, for me, on any given day, I couldn't pay my bills when I was on the truck. Now that's on me. I'm not blaming EMS, although I only made like $10 an hour in any given situation. Never made more than that. And that was pissy back then. And now you're making 15 an hour, 16 in some places, you know, depending on what's going on. And that's okay. It's still not great. Still doesn't equate to more than 35 a year. It's less than that, actually. But the point was, on any given day, I could have had a fight with my wife before I came to work. I could have slept bad. I could have, mentally, no, I can't pay my bills right now. What am I going to do? And I'm facing dilemmas. So poor attitudes can be just from human life. Poor attitudes can absolutely be from burnout, from just life, bad choices, whatever. So the thing with proctorship is it depends on how you set it up. This is why I'm going to defend the poor attitude thing. Because number one, you got to learn how to deal with people who have poor attitudes. You just do. I worked with Jack Mundy. Actually, he precepted me on some of my trucks, is what I meant to say, when I was a student. Jack Mundy, if you've ever known him, he's a very stoic guy. He's very quiet. He's got a very stern demeanor, is what I'm trying to say. He has a very stern demeanor. And as a young kid who's damaged on the inside, and I wanted everybody to love me because I had issues, and I really, really connected with the people who would just talk to me, who would just say, yeah, I had one crew, they wanted me to come back because for 12 hours that I rode, I was supposed to do 8. They said, why don't you hang out later? It's cool with they called their captain. He said it was cool because we ran 0 calls at a busy station in Athens. At the time, it was a station down by the strip club. When St. Mary's was the hospital was still St. Mary's. I think all the EMS is national now. But it was the St. Mary's EMS station on Baxter Street, right down from the strip club. And they told me stories about they love to run calls at the strip club, because everybody's naked and looks good. But we did 10 to 12 hours of no calls. None. And so, they apologized. They tried to help me out the best they could. We did some territory studies. We went and visited some ERs. They tried. There was just no calls that day. Nothing was going on. So, but they were really good preceptors because they took the opportunity to do kind of what I do here, teach me about the life of EMS. Okay, we don't have calls, we don't have the textbook stuff, but here's kind of what we do. Here's how your life can be affected. Here's some ways you can shape your career. It was a really good third ride. But when it comes to precepting, I think, at least it's been in my experience, you show up as a student to an ER or to an ambulance. And most of the time, the ambulance people know you're coming. Sometimes the ERs don't know you're coming. right? The message doesn't always filter down to the nurse or whatever. There's been many an ER I've shown up and say, hey, I dress in my, the school lab coat that you have to have, my stethoscope, fully identifying, I'm Charles McFall, I'm a paramedic student, and I'm here to do my 8-hour clinical today. Oh, okay, hold on a second. Hey, Susie, you know anything about a student coming? Nah, I don't know about a student. I ain't got time for this crap. I am not making this up. All right, she turns over. Well, I can't. I'm not going to deal with you today. I just can't deal with you today. There's going to be somebody else. I literally got put on a wall for the first 2 hours. Then a patient came in that had some kind of altered mental status, and he was restrained to the bed, but I got put in a seat right next to his bed to babysit him to make sure I do the air bunnies, right? To make sure that he doesn't fall off the bed. I left. I mean, he wasn't going anywhere. He was sedated. There was zero learning done. I was literally reading my book, sitting in a chair next to this guy, and they forgot I was there. They even came in. Oh, wow, you're here? Okay, yeah, sorry. Yeah, you're doing a great job. Keep it up. No, none of the nurses wanted to deal with me. So when I talk about the proctor stuff, the preceptor stuff, it's not always, because proctor I realize is about tests. I'm using the wrong terminology, and I apologize. But the preceptor, because it's not always about, hey, I'm running a great EMS Inc. That's what the company I run. And I have contracted with Georgia Institute of EMS to have their students, and it's going to be a great learning experience. And Terry, you're my best medic. I want you to teach them everything you know about EMT medicine and the life and everything else. And Terry goes, all right, man, it's such an honor. I would absolutely love to do that and do that. I think a lot of times you just show up and it's all of a sudden you're assigned to that truck because that's the busiest truck or that's the easiest truck to put you on or whatever. Yeah, I don't know that on the EMS side a whole lot of thought goes into it depending on the company, right? And definitely in the ER, sometimes it's like, oh, hey, we're glad you're here. We've been looking for you. It's awesome. Thank you for being here early, because I always got there 10 to 15 minutes before I was supposed to be there. So I could kind of get my bearings and figure out. And here, let's give you a tour of the ER. This is Meredith. This is Dr. Brown. This is so on and so forth. Here's where you're going to do this. And this is these are great preceptorship, right? It's hit and miss. And part of that is okay, right? Part of that is because you have to learn every situation. The situation I left, the one where I got to be babysitter, what I learned is sometimes you just got to do what you got to do. Because they literally told me, all three nurses basically looked me in the eye and said, I don't have time for you. I'm not going to deal with this. I don't like students. Go away. And but my school has literally contracted with your ER. I have to get this done. And I had a very limited time, because that's not even to mention the school I went through. There were some hiccups and coordinating with the state on our clinical hours for our class. Then at the last minute, the state said, you know what, we're going to waive the clinical hours. It was a paramedic class. And we were getting some of the stuff like intubation, that they got that worked out, but they were having, for whatever reason, they were having a hard time with the ER and EMS rotations. Don't know why. But the important things, the stuff you've never done before, theoretically, because you're new paramedic, the intubation stuff, the ICU stuff, watching the cardiac rhythm, those they worked out. I don't know why it took so long to do the others. But all of a sudden it's, hey, you've got 2 weeks for a class of 15 people to get 40 hours a week. Hey, Brian D. Bradley, glad to see you. So we're talking about EMS. This is a show I do for Georgia Institute of EMS. And right now we're talking about teaching in the field and how people have bad habits. And while I know what you do for a living, and I know that it might not necessarily apply, I imagine you've got similar stories of showing up to do what you do and thinking, hey, they hired me. Or in my case, it was a student situation, right? It's all students. But, in general, generic terms for everybody, hey, they hired me. I'm going to show up, and they're expecting me, and it's going to be a good day. They're going to show me what I need to do because I'm new to this. And you might show up and go, hey, there's your chair over there. Go sit in the corner, do what you do. What do you do with that? And EMS students get treated that way far too often. But beyond that, when they are active, when the preceptors are active, and they are sitting there showing you bad habits, like, yeah, I'm gonna rip the finger off my glove so I can get an IV done. Don't do that for your test, but this is how we really do it. Anytime you hear those words, this is how we really do it, don't do that for the test, they're wrong. They just are. They're wrong. Man, I want to go back to that sharp thing. You cannot stick a person with a needle and leave the needle out anywhere. There are buckets, and it's almost always within arm's reach of wherever you're sticking your needle. You can't stab the bench. You can't leave needles being left behind the bench. I found more than one. Luckily, my boss, and well, unfortunately, but it's also lucky, but my boss, when I was on the truck, and you're in this period of, hello, Terry Wolf, how you doing? You're in this period of, no, okay, I will stop for a second before I go on with that story. Let all the people who came in knew, we're talking about, with the EMS stuff, preceptors, which is when students go into the field before they're done with school, they have people overlook them, oversee them. And we're talking about how those people are responsible for showing these students in a real-world environment, this is how EMS is done. This is how paramedic medicine is done. And we're talking about the people who have bad attitudes about it, who are burned out, who tell you shouldn't be in the field. Not because you're bad at what you do, but because they hate the field. We're talking about not wearing their personal protective equipment. We're talking about tell them, okay, I'm going to do this way, even though the book says and the test says to do it a different way. So we're talking about bad teaching and bad supervising, essentially, of students, of the people who need the most supervision. So I always found it interesting doing the IVs. Every EMT student, they want to do an IV. And I always make sure to ask the student, what have you learned in class? What can you do? Hello, Ginger. Thank you for joining. Where are you in the progression of class? What have you learned? Well, we've done this, this, and this. Okay. Have you done EKG leads? Well, once. All right. Well, you're going to do all the EKG leads today. Have you done IV? Okay. You're going to, we've practiced it. We just got done. All right. You're going to do all the IVs today. But I'm going to make sure you're good. And the last thing you want to do on my truck when I'm your preceptor is to say I can't, is to freak out and to bail on me. If you keep a profession, and that's my number one thing that I'm trying to teach students when I precept them on a truck, professional demeanor. It doesn't matter if in your head you're freaking out. It doesn't matter if your hand is shaking to go do the IV. I'm sitting here calming, quotey fingers, calming the patient, but I'm also calming the student going, no, it's okay. We're going to, they're going to stick you. They're great at this. Don't worry about it. And it's just this very calm, very positive feed. And you'll see the hands stop shaking and they'll stick. I don't know if I can even show you on camera. I'm a little bit fatter than I used to be, but I used to have really good veins that stood out. And, yeah, I mean, I'm just looking at it. You can almost, I can't quite visualize it here. I can feel it. So you wouldn't be able to see it on camera, but you can stick huge veins, right? And so they go in and they hey, Angie, they, stick the IV and I'm like, cool. And if I see them start pulling in, it's like, hold on. And I'll reach in because I'm teaching them demeanor and partnership instead of chastising them. Say, no, that's not the right step. Do the next step. I will make sure I kind of reach over and hold the catheter while they pull it out because they forgot. It's like, all right, get your cap on, this and that. And it's all good. And most of the time, the student's like, wow, that wasn't all that hard. It's like, no, it really isn't. It's all in your head. Even the difficult sticks, it's all in the head. And either you're going to get it or you're not. It's fine. I'll talk about some of my crazy IV sticks here in a minute, but man, I cannot stand when medics, actual medics, especially preceptors, think because it's after I went to bed at 10 or 11 o'clock at night or whenever, it's after bedtime, that I don't have to wear gloves to stick an IV. I'm sorry, when was the last time a virus, HIV, contamination because you had crap on your hands and now there's crap in their IV site? When does that go? Oh, wait, no, we clocked out. Our day is over. You're right. Do what you need to do. When is the last time? And I'm bad about this too. I have done many an intubation tube with no goggles on and no mask. But stop and think about it. What are you doing? You're putting your face the most exposed area of your body with mucous membranes in your eyes, in your nose, in your mouth. You've got multiple open sites for infection that can come into your body, and you're putting it right next to the largest infection cannon known to man, a human mouth. And if you're doing CPR, it depends on what's going on. I mean, it depends on why you're intubating, but all kinds of things can come exploding up out of there. And that's gross. And you don't think about it, right? You've got your gloves on, and you got your tube ready, and you're moving with alacrity, and your brain's firing, and you're going to tube. And I've been fortunate enough never to have anything explode in my face. But the reality is, it would have taken me one extra second to put some goggles on. Because, yeah, and then I didn't wear glasses. I had no glasses when I was a paramedic. My eyesight was better then. It's a long story. It was an injury. Actually, I have an injury to my eye. It gave me an astigmatism. There, short story. So, but I didn't have any glasses on, so I'm fully exposed face, fully exposed mouth, and I'm, all this stuff, right? And fortunately, nothing happened. Doesn't mean it couldn't happen. It really takes a second to put your goggles on. Now, I never told a student, well, you're supposed to do it, but this is how we do it in real life. If a student ever reminded me of a step, I'm like, you know what, you're right. You're right. I need to work on that some more. I'm going to do it. You're right. I'm going to put my goggles on. Thank you. Because the book is right. The book is best practices. The book is safe. Oh, yeah. Getting the test and medications for an exposure is never fun. Never fun. When something comes up, somebody has MRSA or somebody has tuberculosis or this and that, and there's a standard reasonable exposure. Man, some of that stuff can be bad. Rocephin, I think, is the one that they stab you in the butt, and it burns. It's bad. Cortisone, oh my God, it is so painful. It burns for days. So yeah, your cure is bad. You're right, Johnny. I'm sorry, John. He's an old friend of mine, and it's whatever. Ounce of prevention equals a pound of cure. And that's what I always try to teach. Safety, 3 seconds of safety prevents a tragedy. A lifetime of tragedy. Whatever you want to say there. I wasn't poetic about it. I just said it. I would allow my EMT, because I only precepted when I was a paramedic. So I'd allow my EMT to also share their different views and knowledge, because two people can do it two different ways, as long as we're all within the textbook safety parameters of what will pass a test. So here's some interesting IV sticks that go off on a little thing. So yeah, to wrap that up, that Jeremy had suggested, Jeremy Mathis, is that something that they deal with here at Georgia Institute of EMS is students coming back and saying, Preceptors said, oh yeah, that's how you do it for a test, but here's how we really do it. And it would help. I mean, Ginger, if you could throw me some ways you've heard people or see people say that, I would love to bounce off of that. Any of the Terrys, any of the, anybody. Because I'm kind of running out of steam on the Preceptor thing. But if you go, oh yeah, I saw this, I know Ginger's active working in an ER. I know some of you are out there doing things. Or if you just see that in your own business, like, yeah, I'm an accountant, and legally we're supposed to report blah, blah, blah. But some people are like, no, it's okay, you don't have to do that. It's like, no, you really have to. Some of my best IV sticks, some of my most fun, and you can all share these as well. I think you'll find these entertaining, is there was a biker, a motorcyclist, and he had freaking veins the size of my finger, and it was just, there it is. And, my partner's trying to get it. I'm letting him stick it and this and that and the other. And, you could just see, you didn't have to tie it off or anything. You just see his vein. But we tied it off anyway. We followed procedure. And he goes to stick, and it goes like this. Here's the vein. He goes to stick it. It's like, Kirk. And then it's like, Kirk. It's like dodging him. It won't stop moving. It's like, what are we going to do? I said, hey, wait a minute. And I just held my thumb and like, don't you dare stick me. I will ruin you. I said actually uglier things than that, but I can't say those here. But I will ruin you. Don't you dare stick me. And I put my thumbs on either side of the vein and held pressure, and it kept the vein in place, and he went right in and did it. And it's just fun. Yeah, definitely, Ginger. Feel for a vein, not just look. That's a bad habit. Is I've seen people just go into the hand first. I'm like, why would you do that? I can see all the veins in my hand. Who can't? You know, the hand is the most painful place. Whoa, okay. I understand there are other places you can stick an IV that would be far more painful, but standard protocol, most painful place to stick an IV is the hand and the foot. No, quit being lazy. Quit being, just no. AC, man. That's the best way to, right there at the elbow. Do it. I actually have a scar. I don't know if it's going to show. Yeah, actually, you can see it right there on the camera when it catches up there. That's a scar from an IV. Somebody went to stick me, and instead of going in an angle, they went mostly flat, tore the skin, went through the top of my vein. It was in EMT school. It was another student. And I still had the scar from that. And, that I remember that. I remember getting stuck. I've been stuck on the side of my thumb. Don't have no marks at all. I've been in the hospital for a few days. So when you're there for multiple days, they change up the IV sites sometimes, whatever. But always look, always feel. And here's the thing. Sometimes you can see it and not feel it. You got to take your shot. Sometimes you can feel it and not see it. You got to take your shot. And I actually prefer that. I can feel it, but I can't see it. I just can do that mentally. I can go in by feel and boom, okay, there we are. There's been a few couldn't see it or feel it. Well, anatomically speaking, we got nothing better. We got nothing else we can do. Let's try this. And I'm going to try it one time. And every once in a while that would work. I'd go in, find the vein that you couldn't see or feel, and just make it work. Do the best I can. My favorite, though, we were in the ER. We had a patient in respiratory distress. CHF was backing up on him. And I was working as a medic in the ER. And EMS, it was standard CHF, which is swelling in the arms. You've got overweightness plus fluid in the body. So they were having a really hard time. Nobody could get an IV. And there were 2 or 3 people in the ER doing it. And I just looked over, and she was not topless. But, well, at one point she was, because we did all the EKG stuff. But we had the gown on, but it was only up to the top of the chest. So I had a lot of chest space. And I see varicose possibly, but I see a vein sitting right there in the skin. Like 2 centimeters of a vein. I just see this dark spot that I know is a vein. And it's going this way on the chest. So I'm like, all right, I'll try it. Thinking I'm not going to see, I didn't do my full due diligence. I didn't get my INT cap ready. I didn't get, anything, tape, anything ready. So I'm thinking, I'll never get this. And I went Duke, and surprised the hell out of everybody, including me. I got a viable IV. Can somebody get a cap or something for me? Because I didn't think I was going to get this. And the doctor was like, holy crap, that was awesome. Somebody get this man a cap. I was like, you just got to do what you got to do. You got to do the best you can with what you have. Terry Wolf says, I drew blood on cats and dogs when I was 18. It's all feel with a dog's face in your face, and they're moving around. That's way harder than people. Because, with people, at least you got somewhat of a translucent layer of skin, depending on how healthy they are and how skinny they are. And they will hold still because you'll tell them, okay, Ginger and most Metis kids share plenty of stories where they won't stand still, sit still, whatever. But for the most part, if they want help, they'll at least try to be still. I have sat on a hand before because I just went, all right. And I pulled their hand out, sat down on it so it wouldn't move, and then so I'm basically sticking an IV between my legs. And maybe not appropriate, but you got to do what you got to do. All right, what else we got? What time we got? We still got 20, 30 minutes. What else can we talk about? Because that was really cool. I will talk about, until somebody types something, I will talk about this. So as a student, and you're going in, and you've got to understand the real world. You've got to understand how the world works. I've already mentioned it once today. Anybody can get up on the wrong side of bed. Anybody can have stress going on with their life. Anybody can have the best day ever, right? And you're going to deal with all kinds of patient attitudes is where I was trying to go. Patient attitudes and emotions. You're going to deal with all kinds of paramedic attitudes and emotions. And it is very, very tough to finish your clinical when somebody flat out tells you they don't want you there or they have no use for you and you're a student. Now, that's something that should absolutely be reported instantly to whoever's running your class, whoever your contact point is. That's a good question, Angie. I will get to that. Because if somebody, and that's what I should have done right then in that day in the ER, is called my contact for who was doing the clinicals and say, they're sticking me on the wall and they're telling me they don't have time for me and they're not going to show me crap. You need to jerk their chain. And then whoever does the clinicals would call the head of nursing or whoever their contact is, and do that. I didn't do that. What I did was pouted for a while, was really brooding and pissed off that they put me on the wall and then put me to babysit somebody who didn't need any help. And then by lunchtime, I just left. And I made them sign off on 8 hours. I said, here, sign this. And they're like, oh, you're leaving? Like, if you'll sign this, all right. And I felt robbed. But I also felt okay because I was an active EMT at the time, working with a great medic who every call precepted me. It just wasn't official school hours precepting. So let's go back a little bit. Yeah, Terry, veins do roll big time. Terry Dearman says, the day I thought the paramedic student, or taught the paramedic student doing EJ was a teaching lesson on PPE. Yep. Oh, my goodness. You go for an EJ. And I'm trying to think. I think I've had maybe one on a real person. Maybe. EJs, I hate messing with the neck because there's just so much that can go wrong. I don't like it. It was always my last ditch place to go. I'd rather, like Ginger saying, upper arm, back of the arm, foot, leg. You always keep looking. The EJ was there. I think I've done one, maybe two. I really can't remember. Well, I hated doing EJs. I've been thinking about faces. I don't like people being in my face, so I definitely project that. And the neck is really close to the face, especially if you're going to do a C-collar. I don't really want to, EJ that. I obviously, if I have to, I would always did what I had to do. I did what was necessary to keep the patient alive and to do my job. Now, Angie says, do you handle IVs on children differently than you would an adult? Yeah, I'd have to say so. One, a kid pulls back naturally. So I have no problems putting an arm board on them to keep it still, but to also keep it from moving because kids don't think about that. Oh my God. Okay. So I had this other biker who wrecked, he was drunk and driving on his motorcycle, hit some gravel, slid out, was complaining of back pain. So he C-collared and stuff. And we're taking him to the hospital. And tattoos everywhere. And I pull out, my standard is an 18 gauge needle. 10 is the largest we typically carry, and that was for decompressions and cricoid thoracotomies. 16 was the largest real IV needle we carried, like for the EMS services I worked for. 16 was really the highest they recommended for doing large bore. Maybe 14, but 10 was for the decompression stuff, period. And so 10 is a big needle. 22, 24 is tiny. I mean, 24 is less than this ballpoint pen tip. I mean, it's just tiny. And you only use that on babies if you have to, in my opinion. 18 was my standard. 20 if I had to go down. 16, of course, trauma. If I'm going to do lots of fluids, those kind of things. But with a kid, so I'm talking about this biker, right? So I pulled out an 18 gauge, and it's a short enough needle. To me, it's not that intimidating. He starts crying. Man, are you going to stick me with that? I'm like, normally I don't mock patients to their face. Normally I do the real human thing and let them have whatever's going on in life. But I don't know if I just had a bad day or if it just was so bewildering that he was crying. I'm like, dude, seriously, you've got tattoos all over your body. Those are multiple needles for hours at a time. Because a tattoo needle is not like an IV needle. A tattoo needle is a collection of a ton of little needles that is constantly stabbing the crap out of you. And I'm like, because he made up some excuse about how he could get, maybe he was drunk. I don't know. He was crying. He didn't want to do it. I had to threaten to sit on him because the only arm I could get was across his body. So I will straddle the stretcher and sit on you if I have to, if you don't sit still. And he let me stick it. And I mean, I was done in 30 seconds. So that was weird. But with kids, I have found, and this is something I would teach EMTs for absolutely sure, and paramedics. I have found that with a kid, look him in the eye, treat him like an adult, with respect. Treat them like an adult with explanation, but keep it similar where they can understand. Okay, you're really, really sick. I'm going to take this needle. I'm going to stick it in you. It's going to hurt a little bit. The rubber band I put on you is going to probably hurt you more than the needle. But what I'm going to do is I'm going to do it really fast, and then it'll be done, and it won't hurt anymore, and I'm going to give you some medicine to make you feel better. 9 times out of 10, you do that softer voice, you energetically shrink yourself down. I never hunched my shoulders, and I'm 6'7". I was probably 370 when I was on the ambulance, and so I'm fat, I'm tall, I take up a ton of space. And any kid, even sitting with their mom or whatever, I'm in the truck, I'm towering over adults because of just how big I am in the back of this truck. So there's no real way for me to not be massive. But energetically, I would just kind of take my body down and take my personality down and just talk to them. And 9 times out of 10, I said, and you can cry, you can watch if you want to, you can look at your mama if you want to, you can hold her hand, you can, my partner will hold your hand too, whatever, because I had 2 hands for me to do an IV. So I said, the rubber band's going to hurt a little bit, but I got everything ready. Everything's good. So you're going to feel me tie the rubber band, and it's going to pinch you. And then it will sting you with the needle. It's going to hurt a little bit, and you can cry. And then I will pull the needle out, and just plain old plastic that you won't even feel will be there, and I'll tape it down. We're done. Most of the time that worked. Sometimes the kid was inconsolable. Sometimes they were just that sick or hurt. But yeah. And then you always put an arm board, whereas with an adult, you just tape it real good and say, you better take care of that or they're going to stab you again. With a kid, their instincts are different than their rationales, right? They don't necessarily think linearly, and kids just move. So you take an arm board and we just wrap it with ace bandage around it and leave the IV site open. And they kind of think it's cool, actually, because it doesn't hurt. They have this interesting thing that looks different on them and it's not bothering them. And they kind of think that's cool. So there's that. Terry Wolf says, oh, okay. See you next week, Terry Wolf. All right, still have some time. Trying to think of what else is. Go do your call, Nicole. I've done IVs backwards, where all I could really get access to was from the shoulder. Like I'm standing at the shoulder down. I've stuck IVs backwards, at me and got them. This is not something I would do with students, and quite possibly this was a gray area. I'm trying to think if it was unethical or not, but basically my partner and I would play a game. My EMT partner and I would play a game. Who can get the IV first? And I would always give him the advantage. I'd always let him sit on the bench, where is the perfect place to do it. And we'd all have, I'd let him get his materials out and everything. So he has the arm in a standard trained school position, and he has everything, and he's working in an environment. I would sit either in the captain seat or the jump seat where it's tight, where I'm squeezed in, where everything's cramped. And I wouldn't even get my stuff ready first. I'd let him get all his stuff ready. I said, okay, go. And we wouldn't really communicate it to the patient. And so the bad part is we were goofing. That's the bad part. But the fun part to me is I'd always beat him every single time. He'd have all his stuff set up, and he goes, okay, I'm ready. I'm like, go for it. And he'd have the perfect textbook situation to do an IV, and he's feeling it, and he's looking. And I was trying to show him, and it never worked for him, it maybe worked for you. I was trying to show him it's all in your mind. It's all about that you think you can. And so I'd come over the shoulder, tie off at the top, see the vein, hold the skin, come in backwards, tag it, tape it, cap it. So I'm done. What about you? He'd barely gotten started sticking. And let's see, it's in your mind. You worry about all this other BS around sticking an IV, when it's literally just put the damn needle in the damn vein and be done with it. That's all IVs are. And I think that's a good preceptor thing to tell students and to show students, and a teacher thing is stop overthinking it. Stop worrying about it. Absolutely get your gear set up, but do it fast. Know that you're going to have an IV cap, INT cap, right? Or you're going to have the adapt. You're going to plug a line right in, which I always actually preferred INTs on everything. And then if I'm going to hang fluid, I just put the gator clip on and go in that way. It wasn't a gator. Yeah, they were kind of gator clips. But anyway, it's an adapter to hook the bag into an INT because it's just neater and cleaner in that way. And if you have to change the bag, you're not having the whole pressure and letting bleeding everywhere. So that's. But my thing was always, just know you can do it. It's just a vein. It's just a needle. Let's get it done and move on. And that actually benefited me because there was a point towards the end of my career, my active career, where I didn't stick an IV for 6 to 8 months. It was just always had a third rider, always had some kind of precepting student. I always try to let my EMTs do more, as much as they could. And I would let my EMTs push drugs, but I draw it for them. It's like, hey, here's the thing. Here's what I'm doing. I'm pulling up 9 cc's of saline and 1 cc of morphine. That's the orders we have for. And they watched me do it. I said, you're going to push this whole thing. Here's the needle. And, those kind of things. So I want them to get used to, it's just a freaking needle with fluid in it. And if you do it right, it's safe. So many people get overwhelmed with drugs and, oh my God, because you do get all those hard-hitting warnings, right, in school about not messing up the drugs and documenting everything right and this and that and the other. But the reality is, even if I drew up 10 cc's of morphine, push 1 cc, push 2 cc's, whatever. Make it simple, know what you're doing, and just get it done. Angie asks, what's the most... Oh, I'm sorry, let me finish that statement. So 6 to 8 months, I had not stuck a single IV. And then we get a patient who is a very difficult stick, and they've got an emergent situation going on, right? They're still conscious, but they're definitely sick. They have stuff going on. We need to help them. And my EMT partner and my student would always look at me like, can you get it? I remember going, no, I can't get the heart stick. I haven't done a needle in 9 months in my head. But I went, sure, I'll give it a shot. You sure? Okay, all right, no worries. And I never talked down to him or anything. Not intentionally. Maybe I came out. Okay, so I understand. I went through a dark time. And my partner was Suzanne Ward for this story and for many others. She was a great partner, and I was really hard on her at one point. I just you get close to somebody on the truck, and they become friends. They become almost like your work wife or whatever you want to call it. And just like your spouse, and this is something I had to work with my real wife on, was you take people for granted, and you kind of let your guard down when you should be extra nice to somebody because they're close to you. You got crap on them. So I know there were many times I was very hard on Suzanne, and I apologize for that. And I apologized at some point before this to her. But during the story, I'm thinking I've been going through a whole lot of crap at home. I'm not even sure what I'm going to do with my life. I'm basically making sure this truck runs as smoothly as it could, but I'm letting you do everything. And when they said, can you do the hard stick? I'm thinking, there's no way. But what do? I do what I have to do. I get in there and I say, sure, I'll absolutely do it. And to them, they had no idea that I didn't think I could get it. They had no idea. I'm like, are you kidding me? You've been doing 5 sticks a shift for the last 6 months. I haven't done a single one. All right. And I got the IV because it is up here. 90% of how you do your medicine is in your head. So now to Angie's question. What's the most times you've had to stick someone to get a vein? Personally, there are rules to it, right? There's so many, you have to start furthest away from the body. Because if you stick the elbow, you're not supposed to go down and stick the arm because whatever fluids or anything you push at the hand, whatever, the lower away from the body, the fluid's going to go towards it. So if you stick up at the elbow and mess it up, you can't stick below it because if it works and you push fluid, it just screws up the elbow more. So theoretically, you're supposed to, Ginger, maybe you can help me remember. I think most places say you can stick 2 or 3 times per spot. So theoretically, it'd be 3 in the hand, 3 in the other hand, then 3 in the elbow, 3 in the elbow. I personally have a rule 3 times max, period. Not just per site, just period. And my partner can do it 2 or 3 times max. So that's a total of 6 times. And then we just take them to the hospital and let them do it. Because there are some tools they can use in the hospital, depending on how advanced the hospital is, to help really see. You know, there's a special lighting tool that kind of makes the skin, it makes the veins look better. So you get a better visual target. They can use warm towels to really kind of bring the veins up to the surface. There's other things to do. You're not in the back of a bouncy truck, that kind of thing. So I would have to say 6, Angie, because after that it was like, no. I know there were plenty of times that we just didn't get the IV. Now instead of sitting here all day trying to figure out the IV, we just need to go. So 6 is my max. That patient where I talked about, I don't know if you're here in the room, but I talked about getting the sideways IV on the chest. I did that once and got it, but EMS had already tried to stick her 2 to 5 times. The nurses had already tried to stick her at least twice. And it wasn't that they weren't getting it. Every once in a while they'd get a vein and it would just blow because it was weak. I think she was dehydrated on top of having CHF, and it's a weird situation to be in. So it wasn't like everybody was just missing and I was a superhero. It was, okay, we got it. And in fact, there was even one in the hand that got it, and they went to just push a little bit of fluid slowly, and that was it, blew up. It's like, I just got fortunate and got the one in the chest. But that was probably 10 to 12 IV sticks before we got one with different people doing it. Because rules kind of go out the window when it's absolutely necessary, because doctors can do a cut down, they can do all kind of things, and it's like, okay, we want to avoid this really massive, invasive procedure. Let's get a line. We need to get some medicine in this patient. Let's get a line. So there is all of that. Thank you, everybody, for coming out and putting your comments. Thank you, Terry Dearman, for helping me with a lot of the precepting topics there, and everybody else for putting in. Coming out. Do this every Thursday. I play with the time a little bit. I started about half hour early-ish today. Sometimes I start late, depending on what's going on with the tech stuff. But I would love to hear your experiences with a preceptor. That would be EMSU at GAIEMS.org. I'm pointing down because it's right there on the screen. If you want to call this number to find out more about the classes that we offer, we just started a 14-week class last night for EMTs, and we have a combo class coming up, which takes you from no certification to basic to advanced EMT. That is coming up in August, I think, so very, very soon. You want to know more about getting into the class, 678-561-2368. You want to get to me and email me, EMSU at GAIEMS.org. is where you can send it in, or type, if you're watching this video, type in, as you hear me talk about, type in your adventures with preceptors and the bad advice you've gotten, maybe the bad advice you gave and you regret, or the good advice that you've given because you got bad advice, and this and that and the other. So again, thank you for coming out. Subscribe to the page, that way you know when I'm live and we're talking EMS stuff. And go out, be safe, and love the one you're with. Because you got bad advice and this and that and the other.